So my talk is on secondary and piggyback intraocular lenses. Now these are rarely done. Most of us don't get an opportunity to do them frequently. The location of a secondary lens can be in the anterior chamber, retro-iris fixated, sulcus. It can be in the bag or it can be a scleral fixated lens. Piggyback lenses are usually in the bag or in the sulcus. The reasons for secondary or piggyback lenses are many. You can be doing an IOL exchange because you have an incorrect power, the IOL is subluxated, it has opacified, you have some problems like a refractive surprise, or the lens itself may be causing anatomical problems like can cause endothelial decompensation, you can have chronic endophthalmitis, you might have a uveitic patient or after complicated cataract surgery. So there are many reasons for you doing these implants. But when you're doing it primarily for an optical purpose, accurate biometry becomes essential. In a large series of nearly 500 secondary IOLs done in Germany, in Munich, they found that in their series, the commonest reason was dislocation, then aphakia due to complicated cataract surgery, and 6% of their secondary IOLs was for IOL opacification. That's interesting, isn't it? Piggyback lenses can be primary piggyback lens when we are calculating two lenses because of a very high power like an axial hyperopia. But this is not that much of a problem in recent years because we have manufacturers like CAD Group, Apasami and Zeiss who will make you a custom-made intraocular lens of any power up to 65 diopters. Secondary piggyback IOLs are usually implanted for post-op ametropia, and the options include monofocal, toric, multifocal, and toric multifocal lenses. This is a picture of a Rayner's sulcus toric trifocal lens. So we have these various options, and biometry becomes crucial when you are choosing these implants. As far as refractive outcome is concerned, if you can place it in the bag, you will get the best refractive result. Sulcus comes next. And there is no data saying that an anterior chamber, iris fixated, scleral fixated, that one option is better than the other. The large scale studies don't show much of a difference. But some centers will have their own curious findings. For example, this is about 175 patients in this particular center. They found that you get the best results of gain of 3 lines or more if you are using the lenses in the bag. And secondly, for iris fixated lens, they get the second best results for iris fixated lens, which is against conventional wisdom. So depending on your skill level and your experience, you're welcome to use the secondary IOL in the position that is comfortable for you. The biometry, if you're using it in the bag or doing a scleral fixation, please use standard biometry formulas and calculation. If you're going to implant it in the sulcus or if you're going to iris fixate the lens, please calculate for the bag, and then you can use a simple adjustment from a table in Dr. Warren Hill's site. The table goes like this. For a usual lens of 17.5 to 28 diopters, reduce the bag power by 1 diopter and implant in the sulcus. So this will take care of most of our patients. If you have a patient with hyperopia and needing a power of more than 28, the sulcus power has to be reduced by 1.5 diopter. And if you're having a myope where the in-the-bag power is a 10 diopter or less, you can implant the same lens in the sulcus with the same effect. So this is a rule of the thumb. If you're choosing to do an AC IOL, and this I think worldwide is the most commonly done secondary IOL, please use the manufacturer's A constant. So how do we calculate for piggyback IOLs and in aphakia? So we have to understand that the effective lens position changes, and if you can get this effective lens position approximately correct, your outcomes will be good. So Jack Holliday first presented his Virgin's formula in 1993, and all our calculations come back to this particular Virgin's formula. Though it looks complicated, it can be put simply into an Excel form. You can download this Excel if you just go for refractive Virgin's calculator from Warren Hill's website. And you know the K1, you have a patient with a refractive error and you want to calculate the power. You do the normal measurements, K1, K2 you will have. You do a refraction, you find that he's got a +3 or a -4 or some kind of refractive error. You enter that value here. Post-op, don't aim for a plano, please aim for a 0.25 or a 0.5 myopia, then you're safer. Then you have to calculate the vertex distance. Most of us do a refraction We don't check the vertex distance, but it's usually 11 or 12 millimeters. Then the ELPO, the effective lens position of the lens. So ELPO, it doesn't have to be a guesswork. There's a simple way of finding out. If you're going to put it in the bag, please use the manufacturer's suggested ACD. If you're going to place the secondary lens in the sulcus, subtract 0.5 from the manufacturer's bag ACD and then put it as a ELPO in the Virgin's calculator. Similarly, in a piggyback or in a suture fixated or AC lens, you have these options. All these options are present in this green box here in Warren Hill's website. So filling up this form is very easy. You just take a few minutes of your time. And for these occasional patients, it's worthwhile going there and calculating the precise power of the lens that you had to put inside the eye. Till about 4 years ago, that was the only way of doing it. But today, all our calculations have gone to the back end, and you can use the Barracks RX formula from both the ASCRS as well as the APSCRS site. The Barracks RX formula, this is the one found on the ASCRS site. It's free online, and it will give you calculations for both lens exchange as secondary IOL or for a piggyback lens. So in this light gray zone here, you had to put in the power of the existing lens. Then here's the lens factor of the new lens that you're going to put. So this will be the exchange lens, and this will be the already implanted lens. So if you want to have a piggyback, it will give you the power, the additional power you need. If you're going to do a total exchange or a secondary IOL, it will give you the new power. So this one formula has taken away the guesswork from our calculation. Here's an example which is published in CRST. Here's a patient who had both a spherical and a cylindrical post-op issue. And if you rotate the existing lens, which is at plus 16 T5, if you rotate it from 125 to 101 degrees, you will have the least amount of residual astigmatism. So this will help you for toric rotation also. But this is not enough. What you actually do is you have to do a lens exchange and put a secondary IOL, take away the previous plus 18 and put a 18.5 T7. And if you do that, you will get a post-op result, a post-op residual error of somewhere about 0.15 diopter, which is what we want. Here's an example of a patient who underwent a secondary IOL implant. He is an 82-year-old physician who had a surgery done 5 years ago. You can see the intraocular lens is displaced upward, 2 large L-shaped pearls. Here this has got a open PC, and in this movie we can see the vitreous peeping through the pupillary margin in the anterior chamber. So here's a lower margin of the intraocular lens is displaced upward, 2 large L-shaped pearls here, and here is a small open zone through which he has got quite good vision. But he came to me saying that it looks as if he's looking through frosted lens, and he wanted a solution to this. So did an anterior vitrectomy and then removed the after cataract and then scleral fixated lens. Okay, and he had good vision post-op. These white dots are triamcinolone tape on the lens. So in summary, Barrett's RX formula for precise calculation, use it for secondary and piggyback lenses. Also counter-check with the refractive Virgin's calculator from Dr. Hill's site. And if you're using a custom-made lens from any of the manufacturers, please take their advice and use their proprietary calculations also. Thank you.